my channel. So today we'll be discussing the third section of our gynecology questions discussion. So kindly make sure you have gone through all the rest of the part 1 and part 2 questions so that it will be a little more easier for you. So let's get started. A 24-year-old female patient complains of acute pain in the lower abdomen that turned up after a physical stress. She presents with nausea, vomiting, dry mouth, and body temperature of 36.6 degrees Celsius. She has a right ovarian cyst in history. Bimanual examination reveals that uterus is dense, painless, of normal size. The left fornix is deep, uterine appendages are impalpable, and the right fornix is contracted. There is a painful formation on the right of uterus. It's round, elastic, and mobile. So it is 7 to 8 centimeter large. In blood, leukocytosis with the left shift is seen. What is going to be the most probable diagnosis? So again, we have to keep our stress on one point. She actually have this pain, the acute pain in the lower abdomen. This started after a physical stress. Okay. Then suddenly she presented with nausea, vomiting, all of those features. Then the next point is in her history there is a right ovarian cyst. Okay. And when we checked upon, we found that there is a painful formation on the right of uterus, which is really round, elastic, and mobile, and it has a particular diameter also. So what does this mean? Again, the presence of cyst is confirmed. Okay. And also from the history, there is a history of cyst as well. So let's see the options. So first of all, right-sided pilosalpingus. So this is basically infection of the right-sided ovary. Okay, so in that case, they obviously pain, rise in temperature, all will be there. But in this particular cyst formation, that is clearly mentioned, which will help us to rule out. Acute metritis is again infection which can be easily ruled out because there is a history of cyst. Okay. And also in current ultrasonography we are able to visualize the cyst as well. Then comes the subserous fibromatoma, then basically fibroids. So again I said fibroids always present with heavy menses, and the uterine size will increase. So uterus size increase plus profuse bleeding. So these are the main points. So in our question the presentation is totally different, because as I already mentioned, there's a very important point which says that the acute pain started after the physical stress. Now the options between A and C. So there is a more chance that we can have a thought like, why is it not extrauterine pregnancy or ectopic pregnancy? See, for ectopic pregnancy, there should be amenorrhea, abdominal pain, nausea, vomiting, and all. Okay. So again in question, nausea, vomiting, abdominal pain, everything is mentioned. But see, extrauterine pregnancy is not something that immediately happens after a physical stress. Okay. And the second point is, nowhere in the question it is mentioned that the female was pregnant or she was having amenorrhea. So no such details were given. So this is why this option doesn't match with the question presentation. And finally last is ovarian cyst with pedicle torsion. So obviously ovarian cyst is there. She already have a history of ovarian cyst, and again from ultrasonography we are finding cyst, and now this has undergone, see, when the ovarian cyst is really huge, they have the capacity to cause pedicle torsion of ovaries. Okay, so because of this the ovaries have undergone torsion. This is why she suddenly faced this presentation after a physical stress. It can happen due to sudden weight lifting, maybe because of heavy workout or exercise. Even intense sexual relations can cause pedicle torsion in case of females, those who are having ovarian cyst. So I hope it's clear. So always remember, ovarian cysts that are really huge can cause the ovaries to move, and there's a chance for ovarian torsion. Now the next question is, a 42-year-old woman had hyperpolymenorrhea and progressing algodysmenorrhea for the last 10 years. Gynecological examination revealed no changes of uterine cervix. Discharges were of moderate of chocolate color. Uterus is slightly enlarged and painful. Appendages are not palpable. The fornixes are deep and painless. What is the most likely diagnosis? So she is having hyperpolymenorrhea, basically means increased bleeding, and also dysmenorrhea, pain, abdominal pain during menses. So this is seen since the last 10 years, and clearly in the previous section also we have discussed about the chocolate colored cyst, which is mainly seen in endometriosis, right? So this is again a repetition only. Always remember, chocolate colored vaginal discharge, it basically happens due to the formation of chocolate cyst in ovary, and along with that, when there is intense profuse bleeding and also dysmenorrhea, it is a very much sign of endometriosis. Okay, again, even if we rule out the options, we can find that fibroma always presents with a profuse bleeding, increased in uterine size, never of chocolate cyst. Okay, adnexal endometriosis, again endometriosis is something which is seen, the endometrial tissue is seen outside the uterine cavity. So there can be an option, but here it is clearly mentioned that the chocolate colored cyst is present. Okay, the vaginal discharges are of chocolate color. Then uterine carcinoma, we already know the presentations of endometrial cancer. It is the most common postmenopausal bleeding. Okay, now moving on. On the 10th day after discharge from the maternity house, it could be a 22-year-old patient consulted a doctor about body temperature rise up to 39 degrees Celsius, pain in the right breast. Objectively, the mammary gland is enlarged. There is a that means a reddish color area in the upper external quadrant. In the same place, there is an ill-defined induration, lactostasis, fluctuation symptom is absent, lymph nodes of the axillary region are enlarged and painful. So this question is really easy. First of all, the lady is presenting to clinic on the 10th day after labor, and already mentioned in question there is lactostasis. Okay, so there is milk retention. And what is the next point to be clearly given? The fluctuation symptom is absent. Okay, so this means it is not abscess. So there is no abscess. Along with that, in question itself it is mentioned there is lactostasis. So definitely this is going to be lactational mastitis, which is caused by Staphylococcus aureus. Okay, so this is a very clear-cut question. Now, a 27-year-old sexually active female complains of numerous vesicles on the right sex lip, itching and burning. Eruptions regularly turn up before menstruation and disappear 8 to 10 days later. What is the most likely diagnosis? Okay, so there is just one point which is clearly mentioned. There are numerous vesicles on the labia. Okay, and she is a sexually active female. So now we know that vesicles formations are always seen in herpes simplex virus. Okay, and primary syphilis will present with canker formation. Again, genital condylomas are broad, flat shaped structures. Okay, so they are broad flat shaped structures. They are not vesicles. Cytomegalo infection present within a different form, not genitally. Okay, and then finally bartholinitis. So bartholinitis is also again acute inflammation of Bartholin's gland, which we will see it's coming in coming questions. We can see its presentations. So again, they also never show up vesicles, and even Bartholin infection, they do not show vesicles. Okay, so clearly it is a very much clear-cut question which shows that vesicle formation is seen in herpes simplex virus. So this is how it presents with, okay, numerous vesicles. Next question. A 28-year-old patient complains of discomfort, acute pain in the lower third of the left labia majora. The disease began suddenly after menstruation. Body temperature is 38 degrees Celsius. Left labia majora has a formation to 3 cm diameter with hyperemic surface, extremely painful to touch, and there are symptoms of fluctuation. So first of all, not that there are symptoms of fluctuation, it means there is abscess formation. And now where is the location? There is an acute pain in the lower third of the left labia majora. Okay. And then the body temperature increased, and there is basically a formation of 3 cm dia, which is extremely painful to touch. Now let's see. So what are the options? The options are, okay, first of all, we know vulval cancer can be cut out because we know the cancer presentations are bleeding, and it will also interfere with her personal life, and there are many more symptoms. Okay, so we can easily rule it out. Then fibroids, again we know it is a presentation of profuse bleeding, increased uterine size, and all those factors. Hypertrophy of labia, it can be seen. See, we learned about the cervical hypertrophy, which is in cervical cancer. So sometimes it can be due to cancer as well, or else if there is any kind of STD, sexually transmitted disorders, it can also result in the hypertrophy of labia. So in that case, again, contact hemorrhage, friability, fixation, all these should be seen. Okay, so now the only option is it Bartholin gland cyst or acute bartholinitis? So always remember, in acute in Bartholin gland cyst, there is some accumulation which basically blocks the gland. Okay, so I can say that if we take about the pathophysiology of how the Bartholin's gland cyst is formed, basically the duct is blocked by inflammation or trauma. Because of that, there is accumulation of secretions from the gland, and this forms a cyst. Okay, so again, in case of cyst formation, it does not present with a particular fluctuation symptom. Okay, and most of the time cyst formation is asymptomatic, but in our question the lady is basically presenting the symptoms, and there is also sign of fluctuation. Okay, so this is a major point which will help us to determine why is it not Bartholin gland cyst. So cyst formation is mostly asymptomatic, and even if it causes symptoms, it may just cause some mild sexual interfering pains and all. Okay, so but in case of fluctuation, I mean in Bartholin gland abscess formation, always the pain will be there. Okay, unilateral pain and tender swelling, sexual pain, and fever. Along with that, we can, when we do the pelvic examination, unilateral tender mass surrounded by edema and erythema in the posterior vaginal interosseous is seen. So all these signs make us understand that this is a clear-cut sign of acute bartholinitis. Okay, so the symptoms of fluctuation as well as the location and the rest of the major symptoms like body temperature, hyperemic surface, all these make us to the point that it is acute bartholinitis. So I hope it's clear. So this is how it presents like. Now, 51-year-old patient complains of having intensive bloody discharges from vagina for 15 days after delay of menstruation for 2.5 months. In analysis, the disorders of menstrual function during a year. At the same time, she felt extreme irritability and had sleep disorders. Ultrasound examination results says that uterus corresponds with age norms. Appendages have no particularities, but endometrium is 14 mm thick. What is a doctor's statics? Okay, so first of all, she is a 51-year-old patient. So now she is having bloody discharges from vagina after a delay of menstruation for 2.5 months. So she was having amenorrhea for 2.5 months. As her age is concerned, we can take it as a climacteric syndrome, okay, like a menopause. Then she is bleeding again. So when we checked up, everything is fine. Even the uterus is corresponding to age norms. There are no peculiarities in appendages, but the endometrium is 14 mm thick. 14 mm thick means there is some endometrial hyperplasia. Okay, endometrial hyperplasia. So always know that endometrial hyperplasia is the first step of converting into endometrial cancer. So basically endometrial hyperplasia is an initial stage. So this is why her endometrium is really thick. So here the 14 centimeter means the endometrial thickness is increased, which can suggest that it is an endometrial hyperplasia. So definitely, according to comparing her age and the scenario given, we can know that the most common cause for postmenopausal bleeding is endometrial carcinoma, and because of that we already learned diagnostic curettage. Okay, fractional curettage is the gold standard. So this is again a repetition of the same theory of what we learned, but in a little different pattern. So directly they mentioned about the endometrial thickening, that's it. So know that when the endometrium thickening is increasing, it means that there is hyperplasia. Okay, so endometrial hyperplasia is the initial stage of converting into endometrial carcinoma. Now, an 18-year-old patient complains of painfulness and swelling of mammary glands, headache, irritability, edema of lower limbs. These symptoms have been present since the beginning of menarche, appear 3 to 4 days before regular menstruation. Gynecological examination revealed no pathology. What is the most probable diagnosis? So the points to be noted here is she is just 18 years old. Before reaching, there are some symptoms which appear 3 to 4 days before the regular menstruation. Okay, so these symptoms are usually swelling of mammary gland, pain in mammary gland, headache, irritability and all. And these symptoms are present since the time her menstruation started. Okay, so now what is it? This is what they are asking. So first of all, we have to know what is a premenstrual syndrome. Okay, so when a particular group of symptoms are seen during the last 7 to 10 days of menstrual cycle, we call it as premenstrual syndrome. Okay, first of all, in order to say that someone is having premenstrual symptom, first of all we have to make sure that there are no organic lesions. Okay, there should not be any other pathologies, then only we can say that it is a PMS. And it should regularly occur during the luteal phase of each ovulatory menstrual cycle. Okay, and if the symptoms must be severe enough to disturb the life cycle of the woman, or if she needs medical help. See, most of the time PMS does not need a medical help, but if the symptoms are really severe enough, then it means that she is having premenstrual syndrome which needs medical help. Okay, and she will be symptom free during the rest of the cycle. So this is seen just for the last 7 to 10 days. Otherwise the lady will be completely normal. Okay, now let me tell you what are the symptoms which are seen. PMS means it should have depression, hopelessness, anxiety, liability, anger, difficulty in concentrating, appetite changes, changes in sleep, even feeling so anxious, out of control. And there can be some physical symptoms like breast tenderness, headache, bloating. So most of us will be having all these things, but in our case it is not affecting our daily life, right? That's 7 to 10 days, so we don't have to go for a medical help. But if in case the patient life is getting affected due to these symptoms, so out of all these symptoms at least 5 should be there to say that a lady have PMS, and after confirming there are no other organic pathologies. So now coming back to our question, she is an 18-year-old girl, so she is having mammary gland swelling, painful, headache, irritability, edema. So all these things are the symptoms we mentioned. And see, the day it appears just 3 to 4 days before regular menstruation. and this is present since the beginning of menarche. And finally, what is the important point here? Gynecological examination revealed no other pathology. So there are no organic lesions, and this is present since the time her menstruation started and the day of appearing. Okay, it is just appearing 3 to 4 days before regular menstruation. So this clearly shows that it is a PMS. Okay, so there is not even no point of looking into other options even, because this is a direct theory question. Now, a 30-year-old patient consulted a doctor about menstruation absence for 2 years after labor, the loss of hair, body weight loss. The labor was complicated by hemorrhage caused by uterus hypertonia. Objectively, the patient is asthenic, external genitals are hypoplastic, uterus body is small and painless, the appendages are not palpable. What is the most common diagnosis? Okay, in part 2 section also we have discussed the same question. As I already mentioned, whenever there is a postpartum hemorrhage, it can always lead to anterior pituitary necrotizing. Okay, so postpartum necrosis of anterior pituitary, which can happen due to the bleeding which occurs during the postpartum period. Okay, and definitely that particular syndrome is known as Sheehan syndrome, and we already learned in Sheehan syndrome all the anterior pituitary hormones are decreasing. So this is why there is amenorrhea, there is failure to lactate, and even the patient can present with decreased TSH symptoms. So like hypothyroid symptoms can also be seen. So again, this is a repetition of the same question which we already discussed. Again, in the same base paper you can find the same question again and again with a little different content. A woman consulted a therapist about factibility, significant weight loss, weakness, loss of appetite, amenorrhea for 8 months. She an year ago she born a full-term child. Hemorrhage during labor made up around 2 liters. She got blood and blood substitute transfusion. What is the most probable diagnosis? Again the same question. Okay. Now moving on, a 54-year-old female patient consulted a gynecologist about bloody discharge from the vagina for 1 month. Last menstruation was 5 years ago. Gynecological examination revealed no pathological changes. What is the tactic? Again, this is the same repeated model only. Already we learned the most common reason for postmenopausal bleeding is endometrial cancer. So the gold standard treatment is fractional curettage. Now, a 28-year-old patient complained about prolongation of intermenstrual periods up to 2 months, hirsutism. Gynecological examination revealed that ovaries were enlarged, painless, compact, uterus had no peculiarities. Pelvic ultrasound revealed that the ovaries were 4 to 5 cm in diameter and had multiple enlarged follicles on periphery. Angiography, X-ray of skull base showed that cellular region was dilated. So what is the most probable diagnosis? Okay, so she is a 28-year-old female. She is having a prolongation of intermenstrual period. Hirsutism is there, and ovaries are enlarged and painless. And clearly, they say about the pelvic ultrasonography, which says that ovaries were 4 to 5 cm in dia and have multiple enlarged follicles on the periphery. Okay, so as I already mentioned, to diagnose PCOD, always keep in mind 3 things should be there: either oligo or anovulation. Oligo means, just like mentioned in the question, a prolongation of having menstruation, or complete anovulation. Then hyperandrogenism. See, hirsutism is a product. Why does hirsutism happen? Because it is due to hyperandrogenism. Okay, the androgen is more in her body, this is why there is hirsutism. And finally, polycystic ovaries in ultrasonography. So all these 3 points are always needed to confirm that someone is having PCOD. Okay, and always remember, Stein-Leventhal syndrome is the other name for PCOD. Okay, now let's see the options. Sheehan syndrome, we know it happens due to postpartum bleeding. The history of question doesn't say anything about that. Algodysmenorrhea is painful menstruation. It is not a complete diagnosis. It can be just a symptom said by the patient, or it can be our preliminary diagnosis. Okay. Morgani-Stewart syndrome. This is a cranial malformations which is seen, in which the question presentation and the option do not match. Premenstrual syndrome, which we already saw that it should be happening without any organic lesion. Okay, if we take the ultrasonography, if the ovaries are not having any lesions, and if the lady is having some particular symptoms in the last 7 to 10 days of menstrual cycle, then only we can say it is PMS. And finally, PCOD. We know that PCOD means there should be an ovulation, there should be hyperandrogenism, which lead to hirsutism. Okay, excessive hair growth. Hirsutism basically means excessive hair growth. And finally, polycystic ovaries. And always remember, the basic pathology in PCOD is obviously the excessive androgen production only. And remember, PCOD is also known as Stein-Leventhal syndrome. Now, a 28-year-old patient had been admitted to the gynecological department 3 days after a casual coitus. She complains about pain in her lower abdomen and during urination. Profuse purulent discharges from the vagina. Body temperature rise up to 37.8 degrees Celsius. The patient was diagnosed with acute bilateral adenitis. Supplemental examination revealed the 4th degree of the purity of vaginal secretion, leukocytes within the whole visual field, diplococcal bacteria located both intra and extracellularly. What is the etiology of acute adenitis in this patient? So such a huge question, but there are only 2 main points to be noted, which says that there is a profuse mucopurulent, basically purulent discharges from the vagina, and when we already checked it under microscope, we found that it is a diplococci bacteria. Okay, now coming back to our options. Chlamydia, as I already mentioned, they can produce mucopurulent discharge, but it is not a diplococci. Okay, it is not diplococci bacteria. Coli bacteria, E. coli, all those are causing issues related to colon. Okay, enteritis or enterocolitis and all, not purulent discharges from vagina. Staphylococcal infection also, it has a different presentation. It does not cause profuse purulent discharges. Okay, and already we know coliform bacteria or staphylococcal, all these are not a diplococci. And finally, Trichomonas vaginalis. Again, they give out green frothy vaginal discharge. And the second thing is, Trichomonas is a parasite. It is not even a bacteria. And finally, from our previous knowledge even, we know that gonorrhea is actually a diplococci bacteria, and they already produce mucopurulent discharge. Okay, so this is again a very much easier question, because they already mentioned it is a diplococci bacteria and there are profuse discharges from the vagina. So that's it for today. See you next topic. See you next video with more discussions. Thank you.